based on the RAND studies, pricing studies, and that was in 2022. I'm sure they're much higher now. So this growth in prices and spending has been the main problem, the main market failure. It's also resulted in a massive transfer of wealth from hospitals and providers, so the general public to hospitals and providers. And that's been fairly well documented by people like Jerry Anderson. But due to anti-regulatory sentiment, since the passage of the ACA, there have been only diffuse, what I'll characterize as diffused and non-targeted regulatory interventions, and largely slogans, things like ACOs, value-based payment, cost growth benchmarks. I think there's literature out now, and I've cited the literature that point to the fact that these approaches that are not really enforceable have not been effective. So we have a situation of dominance by hospitals, that particularly those that are highly consolidated, high prices, reduced affordability, inequities, have and have not providers. Now, the current predicament, I'd like to talk about the dynamic because there's a lot of consternation about, oh, well, the hospitals have to charge much higher prices to commercial payers because the costs are high. And so we need high prices to fund those, and public payers underpay. That's the kind of the general mentality that you hear a lot about. I strongly disagree with that mentality and those conclusions. The literature conclusively shows that consolidation leads to higher prices of spending. That has been what has occurred in the last 25 to 30 years. And ironically, we have this situation where we have both high prices and high costs, which seems kind of contradictory, but that's the case. And MedPAC, he had Ariel early on commented on some various aspects about Medicare payment. But MedPAC has really, I think, concluded correctly that the situation has been caused by, in large part, nonprofit managers motivated by expansion of power and influence acquisitions, so-called empire building, and competition over input costs have bid up the hospital cost levels nationally, and resulted in extreme operating inefficiencies. So as hospitals increased their pricing power, increased the amount of spending and the revenue they generated, what did they do with it? Well, the nonprofit hospitals primarily spent it on their cost base. As a result, over this period of time, costs have gravitated up to very, very high levels by any general external measure that you might look at. MedPAC has correlated this with hospital prices in other developed countries, and Medicare prices, even in the United States, are much higher than the prices hospitals in developed countries receive. So we have this negative situation where we have very high cost levels in the US, and so that it makes Medicare prices appear to be too low when they are really not too low for efficient hospitals. And MedPAC has demonstrated this, that hospitals in the US that are under pricing pressure because they have high proportions of public payers or dominant private payers have much lower costs. So that's the kind of the overall mechanics, I think, that have put us in this current situation. Now, there's also a lot of literature that show the negative societal impacts, both on affordability and other factors of rising prices and spending, shifts of wealth from the public to providers, but also reduced wage growth, increased cost sharing by enrollees, and increases in suicides and mental health and opioid abuse issues. So I've tried to highlight some of that literature in my footnotes. The Vermont current strategy, obviously Act 68 and reference-based pricing, I think that's a very, very good a first step. As I said, MedPAC has shown that efficient, lower cost hospitals can make profits on Medicare levels. We're starting out in various states like Oregon, Washington has passed legislation along these lines at 2 times Medicare, which should be more than adequate for most hospitals. There's a potential then now to give teeth to the budget review process in Vermont by utilizing reference-based pricing. I strongly support that. Other experience, I think Braz may have touched on this. I think there's a value, and I'll emphasize this throughout the presentation, to taking incremental approaches to rate regulation. As I said, rate regulation can be disruptive, so an incremental approach is probably worthwhile considering. I don't know that Rob's mentioned this, but in Oregon, one of the unintended consequences of setting reference-based pricing is that the third-party administrators initially interpreted that 200% cap as the price. So in some cases, prices gravitated up to 200%. Now, they did correct that in Oregon by an administrative rule that the price that would be paid would be the lower of billed charges, the price cap, or existing prices. So they tried to address that issue, but that's something that the Green Mountain Care Board should be aware of. It was obviously applied to the largest hospitals, so tried to exempt the smaller hospitals that are meeting or experiencing other challenges, and then evidence of savings and also little evidence of substantive harm. Although I'll talk a little bit about price control and other things like volume a little later. It's easy to implement. Rate setting can be extraordinarily complex. So if you got a method that's easier to implement, so much the better. Difficulties in nuancing this system and achieving other policy goals. For one, you'd be tied to Medicare growth if you're referencing Medicare prices. Alternatively, the Green Mountain Care Board does have rate setting authority, so they could impose different growth rates, but then that will create some complexities. So you might want to tier the rates of growth for lower price versus higher price hospitals. And if you're tied to Medicare, then you're less able to do that. But as I said, you might have the authority to kind of disengage a bit, although that there are pros and cons associated with that. It's also not as comprehensive as like a global budget system. And as was discussed early on, when you clamp down on prices, we experienced that in Maryland. We were just setting prices before our global budget system, and volumes increased precipitously when we were very tight on the price side. So that's a potential behavioral response that you should be aware of. So again, I would recommend incremental approach or reference-based pricing. Great place to start to gain experience, have some teeth in rate regulation. But I'd also suggest considering reference-based price caps on just out-of-network hospital services. And explain the value of that. What that approach can do is apply price caps to just a segment of the commercial market, not all commercial payers. So that's good in terms of getting your feet wet with regulation, gaining experience. But it has a significant leveraging effect, conferring more negotiating leverage to payers to negotiate lower prices, and that's because it removes this negotiating strategy that hospitals employ. And I've experienced this directly in my negotiations with the hospital, where they'll threaten to go out of network, bill full charges, generate more revenues with the existing patients that they get. Insurers are loath to have reduced networks, so they routinely acquiesce to these rate demands for higher annual fees. But if you were to set a cap on out of network, that would basically cap the hospital's ability to charge much higher levels and remove this negotiating threat that exists in the market, which is not well publicized, but believe me, exists. And so it might be an incremental step to see if you can generate some savings. And in fact, RAND did a study, Erin Duffy, several years ago, that tried to look at a state level what savings might be generated from this. Setting price caps at 200%, she estimated about $135 million per year could be generated by conferring that leverage back to private payers. Now, Act 68 also mandates a move to global budgets. I think that's a great approach, particularly after you've gained some experience with the rate setting through reference-based pricing. There are advantages to global budgets, more comprehensive. It's real time. If there's strong enforcement of hospitals' prices and budgets, it can be structured to be formula driven and somewhat automatic, which I think is also a big advantage. It gives you much more compliance enforcement authority over prices. If volumes increase under a global budget, then rates if volumes increase, then rates will decrease, so that the product of prices and quantity would equal the global budget, regulated global budgets. That's in essence how Maryland has the mechanics of the Maryland system, but it's very similar to a system that we developed back in 2014 for Vermont, which assumed a very, very strong level of compliance on prices. But I'll talk about that model in a minute. More extensive model, obviously, it could be structured to be less complex than Maryland. Maryland was very complicated because our statute required us to set individual prices and prices that were equitable and related to costs. So when you have that infrastructure of pricing imposed on the regulatory system, it creates some level of complexity. I think if you focus just on regulating budgets, because you have pricing control, that can make the system less complex. But a global budget have a certain prerequisites. I think it should be all payer. That requires a Medicare waiver. That will be challenging in this current political environment, but perhaps in the next 2 or 3 years, it might be more feasible. You need these strong incentives to control volume, which global budgets have. Under a more expanded model, an all-payer rate-setting model, you could increase budgets and rates differentially to address high versus low-price hospitals. You could put in an assessment to finance uncompensated care across all payers. That was a hallmark of the Maryland system. It also added a lot of financial stability for hospitals across the state, and was one of the reasons why hospitals initially strongly supported rate setting in Maryland. You can include an incentive structure to improve quality of care. I think that's a little more challenging, but it's certainly worthwhile attempting. Maryland has a lot of metrics that they've used to implement that type of system. What I've recommended in the past is what I would term as a flexible global budget. And this is the model that we proposed in 2013-14. We prepared a simulation using one of your hospitals, Rutland, operating data. It was based on a model that a colleague of mine developed from Maryland and Rochester in the 1980s. As I said, the early Maryland global budget model and the Rochester model was very successful. We'll discuss the advantages of flexible versus more fixed budgets. Fixed budgets had a hard cap, and that's the model that Maryland uses now. And I'm not a fan of fixed budgets. But I think in general, Vermont is very well positioned to implement global budgets. And it has a lot to do with your delivery system and also your geography, where you've got populations that are naturally mapped to hospital delivery systems. I'm not telling you anything you don't know. You're well aware of this. But we felt like that was a very positive kind of base situation to operate from. And as I said, we developed a flexible global budget model that made use of these regional delivery areas as a basis for global budgets. Now, again, we proposed this flexible model. It was used in other jurisdictions. It was used in Maryland. It was an early iteration of the Maryland model from 1975, 76 to 1992. It used what was referred to a mechanism of a hospital volume adjustment system. And it just gets a little bit technical, but I'd like to illustrate the rationale behind using that as opposed to the fixed budgets that Maryland now uses, which don't vary at all or very much with volume change. I think there's significant weaknesses to the fixed approach. We've seen this in Maryland. It encourages stinting on care, dramatic increases in wait times for ED care. I think also probably elective procedures, wait times have increased, although that has not been documented. It encourages shifts of care from hospitals, services under their global budget to non-hospital providers, many of whom they own. But when you shift services from a global budget to non-hospital providers, you get double payment because the hospitals retain the money under their global budget, but then can get paid for it a second time when it shifts out to a non-hospital facility they own. We also found that fixed budgets were very rigid for all hospitals and imposed significant constraints on academic medical centers who are looking at new drug development, new technology development. It also transferred significant financial risk to hospitals in rural areas, small hospitals, to see fluctuations in their patient population on other things, pandemics, other natural disasters where they're very vulnerable to revenue fluctuation under a fixed budget. Now, just wanted to illustrate the difference in the three major reimbursement approaches: fee-for-service, flexible budgets, and fixed budgets. Fee-for-service, as you all know, has a significant flaw. It overpays for hospital services, new services, and it also underpays them when hospitals reduce their service use. We've estimated in Maryland that hospital costs are about 50% fixed and 50% variable with new volume, incremental volume over baseline. And so an example of overpayment with fee-for-service, hospitals are paid essentially 100 cents on the dollar for each new service they provide. So that's their marginal revenue they get when they admit another patient or add tests or other types of services, sleep studies. And as a result of being paid handsomely, marginally under fee-for-service, they tend to do unnecessary services or low-value services. And what we found is that hospital marginal costs are more like 50% or 50 cents on the dollar. So when you're paid 100 cents on the dollar for a new service, but your cost to produce that new service is only 50 cents, there's a tremendous amount of excess marginal costs that the hospitals can earn under fee-for-service. And that's the primary reason why hospitals attempt to do that, because they can pad their bottom lines in that approach. Now, if you compare that to a fixed global budget, which is the other extreme, it's the one that Maryland uses now, you get essentially zero additional payment for new services. And so hospitals face, I think, extreme incentives to reduce their service use. And in fact, in Europe, they started out in France and Germany with fixed budgets, but it resulted in stinting on care, and hospitals in those countries moved, or the policymakers moved to more flexible approach or back to fee-for-service. In Maryland, there is evidence of stinting and shifting of care, significant shifting of care to non-hospital providers. And shifting of care will benefit the hospitals under a fixed budget because they basically get paid twice. Hospitals found in Maryland it's easier to shift the care than to actively manage the care. So have to be worried about that double payment type of approach if you adopt a more fixed budget type of structure. But by contrast, the marginal approach, which was implemented in Maryland in that early period, 76 and 92, and then other jurisdictions like Rochester and the Finger Lakes, equated the amount of marginal revenue that a hospital would gain from a new service to their marginal costs. And they did so via this volume adjustment mechanism. So that volume adjustment mechanism neutralizes the incentives to increase volumes unnecessarily, but it has a reverse supportive effect, which is it pays hospitals for their fixed costs, no matter what volume does. So volumes decline, hospitals are not disadvantaged, and this helps support smaller rural hospitals, particularly in areas where they have declining patient populations. So the overall conclusion is flexible approaches more right sizes individual payments. And you can see this kind of, do this quickly because it reiterates what I just said. Fee-for-service overpays hospitals. Fixed budget, I think, is too restrictive for hospitals, results in stinting in care, and will also a shifting of care to non-hospital providers, which can result in double payment. And also, I think, excessive levels of risk, whereas I think flexible budgets are kind of that sweet spot that equates marginal revenue with marginal cost for incremental volumes, and it will not result in increases in low volume services. Now, there are weaknesses to global budgets. Problems and inequities arise when it's not applied to all payers. I think that's the one fundamental weakness of the AHEAD model. Just applies it to Medicare only. Or if you have a situation where you've got all payers in, but you got a big payer like Medicaid out, that's problematic. It creates conflicting incentives. I've talked about the other weaknesses of fixed global budgets. But the other thing to be aware of too is that these models, and this is a true to a certain extent with reference-based pricing, they don't address the fundamental price inequities that exist, which are extreme currently. So that's a separate policy objective that I think would have to be addressed over time to try to bring high prices down and lower prices up at the individual patient level. So it's something to consider. Um, Key steps in model development, you develop the rate base. I think it's best to use historical revenues to start things out. You define the population subject to the global budget. As I said, Vermont's in a good situation because you've got these regional delivery systems that are naturally mapped to individual hospitals. It's you determine the adjustments. You can do various adjustments like add uncompensated care funding or seed funding to promote more effective care management in primary care. If you opt for a flexible global budget, you'd use a volume adjustment. But then, key element to all of this, and you're in the process of doing this, is creating strong individual rate and budget and enforcement and compliance mechanism. I'm not that knowledgeable about your rate review process, but I would say that that's probably your Achilles heel, is that you haven't had that strong targeted rate setting compliance heretofore. The other advantage to this approach is you can create a formula-based prospective method, and I'll illustrate that. I think that helps in a variety of reasons, one of which is it makes the system more automatic and less subject to discretion. And you could also tier your rates of growth over time. Maryland has a lot of experience comparing high and low price hospitals to give an entity like the Green Mountain Care Board the background about how to make those sorts of adjustments and where to make them. And in the meantime, you should collect data on all non-hospital providers to see have a better sense of what's going on in the rest of the delivery system. I wouldn't recommend setting rates at this stage for non-hospital providers. I think there are other ways of approaching that. One is you have a high proportion of physicians that are employed by hospitals. If you implement global budgets, you could also implement a payment system that provides incentives for those employed hospitals to be aligned with the incentives of the global budget. That's one of the things that we had recommended when we were doing work in Vermont previously. I'd like to very quickly just show an example of the formula-based approach to hospital global budget. I think it's best to start out with the status quo revenue of hospitals. That's less disruptive from a delivery standpoint. In Rutland, we proposed using Rutland's base net revenue, which was about $250 million. They weren't making much of a profit at the time, so I'm assuming in this example that their expenses are basically at break even. So in the base year, assuming no profits, but because their service area was naturally mapped to the hospital, you could quantify the demographic changes that would occur over time. If you get more people, more elderly people, there's a higher demand for hospital care. You can quantify that. That's legitimate to make an adjustment. So I've got a placeholder for that. You can also make adjustments and should make adjustments for hospital input cost inflation. The metric to use there is a Medicare market basket, which quantifies that. There are other metrics, but you want to pay hospitals for things that are beyond their control. And underlying input cost growth are largely beyond their control, as well as demographic changes. But you have a system that could be somewhat formulaic. And start out with $250 million. You adjust the budget up over time for those two factors. In this example, I'm assuming that the model creates incentives for the hospital to reduce its costs. And this is kind of an ideal result. You control costs, hospitals' profitability increases. That's what happened in Rochester. And then you can apply additional adjustments. In this case, I show the volume adjustment, which would kind of create a more softer, gentler approach to global budgets and via the volume adjustment system. But you can also apply other adjustments like an assessment for uncompensated care to finance that across all your hospitals, and also a quality pay for performance methodology. I did a pro forma. This is based on National Health expenditure data nationally from 2014 to 2020 that's released by CDC and Medicare. I looked at what your GDP growth has been in terms of incomes over a period of time. So I picked a number, 2.5%. But again, rate setting can be somewhat of a tautology. If you have the ability to control prices and budget growth, you can meet a target. So the result of the savings is if the state had controlled hospital spending to 2.5%, and that includes both price and volume, it could generate savings from -9 to 300 million per year based on your actual results. And the cumulative savings over that period, 2014 to 2020, could have been a little over $1 billion for all payers. So this is just more of the actual raw data that I use from the National Health Spending Account. So he shows your actual growth, which had been more like 4.1% per capita in hospital expenditures, shows the non-hospital growth as well, which had been 3.78. Here's your population growth. But then if the model had been implemented 2014 and had been successful, it could have controlled that hospital expenditure growth to more like what incomes have been growing at, and that would have resulted in cumulative savings of over $1 billion. So that is ideally the way the model would work. But there's evidence in Maryland that it has worked that way, back to their implementation of their budgets. Now, key weaknesses, and I'll wrap up with this, is there's evidence that you could have regulatory capture, regulatory failure. I think that's existed in most jurisdictions, if not all, where rate regulation or review has been implemented. So obviously you want to think about ways of avoiding, if you address market failure, that's great, but you want to avoid regulatory failure, because rate setting, as I said, there's a danger that it can really disrupt the delivery system. And with regard to regulatory failure, here's kind of a general definition. Excessive complexity, largely due to repeat attempts to revise the methodology. There's also the squeaky wheel phenomenon. It's occurred particularly in Massachusetts and other states, New York, where the squeaky wheels, the powerful hospitals got favorable changes. All over time led to this layering of the complexity of the model where incentives became really obscured and unintelligible. We see this in New York in particular, New Jersey, and some of the other states. Examples, NIFRM, which is the original New York rate setting system, was notorious for regulatory failure, largely because they revised their statutes 7 times over 12 years, and allowed for favorable amendments and changes that really undermined the system, made things very complicated. New York also the system was controlled by the Department of Health, and they had other issues that they tried to deal with, like the Medicaid budget. So a lot of the rate reductions were tied to the Medicaid budget, and that created some level of complexity. There were other issues and examples of this in Massachusetts, and Washington State had a budget review process, but it was highly contentious and very detailed, and each and every year created knife fights in the state. It wasn't formula based, it wasn't automatic, and that led to their demise of their system. I think there are ways of forestalling regulatory failure, create a system that's more macro oriented and more formula based and automatic, so there's less discretion. That was particularly the case in Washington State, where it was very, very contentious. States also need to have strong compliance over rates. Connecticut's rate setting system failed because of the inability to enforce rates. A political independence of your body, regulatory body, is also very important, separate from the Department of Health, who have other masters that they have to answer to. Rate setting also is criticized for doing too many things. So it's best to take an incremental approach and focus on your key market failures. But I'd like to emphasize, too, this idea of establishing significant consequences for failing to meet your quality of care and also affordability standards over time. That's a very important element to forestalling regulatory failure and regulatory capture. So I'll finish with a discussion about regulatory capture. Most of you, I'm sure, are aware that this is a theory popularized by George Stigler back in the 1950s and 60s, where regulatory entities successfully influence regulatory agency to focus policies to achieve their goals as opposed to the broader goal of the public. Two different types of regulatory capture from the literature. One is more materialistic capture, so-called bribes, or things like, which is less common in the United States, fortunately, or things like revolving door, where staff or commissioners of the regulatory body eventually leave and then accept lucrative positions in the regulated industry. That occurs quite frequently, and that can have an impact and that could be negative. Cognitive capture, I think, is the more predominant form of capture, which is really just repeated influence by the regulated industry on both commissioners, but also staff. And in Maryland, Maryland made the mistake of having work groups that met weekly, where staff had to interact with the industry repeatedly. And I think over time, it's this kind of a theory of behavioral economics that does have an impact. So it's not to say that staff shouldn't meet with the industry, but you need to protect staff and protect the regulatory body from those sorts of cognitive influences. But John McDonough, who is an academic from Boston, has concluded, did extensive research that rate setting generally didn't result in the most debilitating forms of regulatory capture, although it's something, again, to be very, very focused on. So I'll wrap up with just talking about some of the ways to forestall capture. They have to do with the type of agency. One without enforcement authority obviously is less susceptible than one with. You're in the latter category, so you have to be, very concerned now that you're generating even more regulatory enforcement capability of the likelihood of capture. The structure is also important. Independent public utility style commissions are less susceptible to failure and capture than systems that are run or strongly influenced by a Department of Health. Composition is important. I would recommend having no commissioners, board members that have a direct tie to a regulated industry. There are other examples of that. Leadership, which is more of an amorphous concept, but leadership is incredibly important. But ways of avoiding that is having restrictions on that revolving door dynamic that I mentioned. This is another important element to help protect against capture and failure, having very, very explicit performance goals and significant consequences for hospitals and the entire industry if you're not meeting those. And that can be done if you negotiate a Medicare waiver. CMS, CMMI are likely to impose those types of consequences. Maryland, that was the key reason why our system continued, is that we had a doomsday scenario if rate setting were to be unsuccessful. The approach also, I recommend a macro-oriented approach, more formula-based. Make sure that your agency is well-funded and you have good salaries to attract competent staff and retain staff. You can avoid this revolving door dynamic that exists. The nature of your statutory authority is important too. Maryland had a very broad statute as opposed to a state like Massachusetts or New York, where the rate setting methodology was in the statute, and it caused this process of revising the statute year in and year out and through the political process, which added to the regulatory potential for failure. Transparency is very important, having adherence to the Administrative Procedures Act. And then, as I said, it's nice to have a kind of what I refer to as a doomsday scenario, whereas if rate setting went away, in Maryland, we would have lost our enhanced Medicare payments and would have resulted in a reduction in Medicare revenues of $2 to $3 billion. And so it really galvanized political support for the system. It's not something that you necessarily can duplicate there, but it's something to keep into consideration, this idea of creating consequences. Cultivating other sources of expertise is very important. Found that academic leaders are often more independent and understanding of health policy, and they're very helpful to have advising the board. I'll finish with next steps. I can suggest considering out-of-network services and prices just to see how that might roll. It's a less extensive form of rate setting. You should tap into some of the information from Maryland with regard to quality and pay for performance. Maryland also a significant experience adjusting and analyzing hospitals' prices on a case mix adjusted basis to identify efficient, lower priced versus less efficient, higher priced hospitals. That can be useful in tiering rate increases, and also achieving other goals. Consider the flexible budget approach that we developed previously, and I have a list of sites for all of my presentation too. So I'll stop there and I'll see if I can figure out how to get rid of this system so we can have a conversation. I don't know. Are you still seeing my slides or?
No, they're down.
Okay, good. All right. So let me stop here and I'll open up for questions. I've met some of you in the past, so it's good to see you again. So happy to answer any questions.
Great, thank you. And thanks, Member Holmes, for chairing while I had to run out. And Mr. Murray, really nice to see you. You've had such a tremendous influence on my career in health policy that I wanted to thank you for making time for us again. You've made a lot of time for myself and other board members over the last 3 years, and it's been really impactful. I would recommend anybody to read Mr. Murray's Managing Regulatory Failure and Capture, which is available from Milbank. It is a piece that I read every single year, at least once, and it's had a lot of influence on me. So thanks for your scholarship and your work here. I will turn it to the other board members to open with their questions and any conversation they may have for you.
If it's all right, I'll kick off again. Thanks, Mr. Murray. We've met before and talked, and I appreciate it as well. Going early on in your comments today, you discussed how literature shows that the all-payer rate-setting systems were most effective, and I was, curious because I think a lot of what we're thinking about is reference-based pricing with commercial, and your thoughts on what would be the risk of doing just the commercial population in our rate-setting methodology in Vermont.
I think the general advantage of all payer is pretty obvious. It's just it's any type of system. It's good to have uniform incentives across all payers and individual circumstances. So the all payer system accomplishes that to a certain degree. When you have a system that is single payer or not single payer, just focused on one category of payment. So I'll take an example of the AHEAD program. The AHEAD program just says you have to set a global budget for Medicare, no other payers. Well, then you have the other payers that have inconsistent incentives and applied to them at the hospital level. It wouldn't be surprising if hospitals greatly restricted the care they delivered to Medicare patients. And relative to the other types of. So I think that's one of the negatives that illustrates this idea of not having uniform incentives, that the AHEAD program will create inequities and also stinting on care for Medicare. So there's a danger that you could see that same sort of dynamic with just setting rates for commercial. But I think there's less of a danger there now than in the past because the rates for the commercial payers are so high. So you're getting less of that type of impact from an incentive standpoint for the hospitals, that they're going to not want to see commercial patients. But that's something you would need to monitor over time, that you could create that sort of inequity. So I think that's the principal concern. The other concern is that perhaps hospitals, if you ratchet down or create constraints on their prices for commercial, is they could start to reduce access to care and the volume of care that are provided to commercial payers. So patients, so you need to monitor that as well. So I think it's really the inconsistency of incentives to create unintended consequences, behavioral consequences that are implemented by the hospital that you just have to monitor. Until you can get to an all-payer system that are the most concerning.
Okay, so the the big risk would be if we set commercial rates below rates of other payers, which I don't think has been on the table. Okay,
Right.
great. One comment I just want to make, when you're talking about consolidation and market power, we have a lot of rural hospitals in Vermont. It's often discussed how, our rural hospitals are not part of systems, but I would, Dr. Song testified for our House Health Committee in Vermont recently in and around the context of discussing private equity acquisitions, and that often rural hospitals, while they are not part of systems, enjoy a significant amount of and some of the strongest market power in the country.
Yeah.
I just want to sort of throw that comment in here, and
Right.
just a shout out for that presentation, which was quite helpful. I guess the next question is, I'm trying to understand sort of like we're talking a lot about reference-based pricing with the future of global budgets, and sort of the spectrum between a reference-based priced rate set budget methodology with commercial NPR caps and some maybe some bumpers on volume and some flexibility in there versus a flexible global budget. How do we transition from one to the other, or what's the difference between those two things? And I guess part of the reason why I asked this is Maryland, my understanding, effectively runs with a fee-for-service backbone
Yes.
in its payment system,
Yes.
so that it's kind of somewhere, but yet we would assume it to be a global budget.
Yeah, well, the Maryland approach does use that mechanism exactly, and that's similar to the mechanism we propose for Vermont. Is a backbone of fee for service, starting out with not changing your claims payment methodologies for any of the hospitals, but giving the board authority to adjust or to regulate both the gross price and the net price of every service. So that to achieve that global budget, as prices go up, then you would have to or as I should say, as volumes go up, you would have prices come down so that the price times quantity equals your global budget. And then that's moderated by that volume adjustment system, which pays on the basis of marginal cost as opposed to, excess. So the idea is to have, I think, a good approach is a hybrid system where you're basically regulating on a fee-for-service basis. And that would mean setting prices and adjusting prices during the course of the year, which can be done without the level of complexity that Maryland now uses, so that you could achieve a global budget, and then also do other types of adjustments, like differentially adjust the rates of growth for lower price hospitals or higher price hospitals. Now, I think you can get somewhat close to that in the meantime, in these early years, by using reference-based pricing to put a lid on your spending growth. But then over time, I think it would be more advantageous to actually set the price and regulate the price of each service, but on an aggregate basis, which the model that we developed tried to do that to make it more administratively feasible for the board. So to answer your question, a combination of a fee-for-service rate regulatory system with a volume adjustment can kind of straddle both worlds, give you the benefits of fee-for-service, but at the same time put a lid on your overall spending because it's moderated by the rate setting authority you have and the budget setting authority, which is enforced by the rates that you actually impose on the hospitals. So sorry, that was a bit convoluted.
No, I appreciate
but
the nuance,
I think a hybrid approach is the best approach to do it, but it will take you time to get there. And this idea of reference-based pricing to give you teeth and to actually meet your goals from a spending standpoint, it's great in the interim years and gain experience with regulation.
Thanks. I'll pass the baton here.
I think I'm next. I haven't met you before. I'm Sarah Teachout, and I'm a relatively new board member. I have sort of 3 areas of inquiry that I wanted to ask you about. One is I'm very interested in your flexible budget proposals and scenarios. And I was wondering, because I was paying really close attention to the sort of adjustments for offering new services so that the hospital can't make a lot of money for offering some types of services versus others. And I'm wondering if you see that working the same way in reverse. So as hospitals reduce services, would it also create a disincentive to reduce one service over another?
Would what create an incentive to reduce the global budget?
There was a slide there about, and maybe I didn't understand it, but adjusting the upward revenue that a hospital can make by the inputs into the service line, so they can't make more off low input, high revenue services than they can off a service. Maybe I didn't understand.
Yeah, I probably confused that slide. Basically, the flexible model would start with the status quo, the existing historical budget, the existing prices that hospitals charge all their payers individually. And you start with that structure, which is very disaggregated, inequitable, and you retain that over time. But then you develop the regulatory authority, which you're doing now, to get your hands around that, so that over time you can control that for all payers and all prices moving forward. But then within that, in a given year, for a hospital, if volumes go up, you're going to differentially give them less of a rate increase, so that the price times the quantity equals their global budget at the end of the year. And so at the end of the year, what matters is the overall incentive, both at the hospital level, which is now effectively a global budget, and also the state level, which is we have control over the entire spending over time. Now, some hospitals may see big drops in their volume, in which case they'll get increases in their price. But you take that into consideration, it kind of comes out in the wash. But if you say, no, we're growing at 2.5%, you can meet that target with these other things kind of going up or down underneath that overall constraint. So the model, again, it's more macro oriented. It doesn't tell hospitals what to produce or what not to produce. It doesn't provide differential incentives for them to overproduce or underproduce. It kind of gives the control back to the hospital, as long as they meet what you can control regulatorily, which is your price and your budget. So again, that's kind of, again, back to this idea of a macro approach that's more formula based.
Okay, then just to follow up on the formula-based recommendation, because it does make a lot of sense to me, and reducing some of the subjectivity out of the decision of the regulatory entity. But doesn't that kind of bake in all the dysfunction and sort of perverse incentives in our system, which I feel like we've sort of reached a crescendo here where we're trying to undo some of that?
Right. Yes, to be honest, it does bake in a lot of the big issues or all of them, basically, you're starting status quo. Again, I've learned over time, and it was our mantra in Maryland, is regulation is very effective. It can be too effective. And the best approach is an incremental approach, so as not to disrupt the delivery system, and focus on the market failures. And principal market failure we've talked ad nauseum is price and pricing power, price growth. And over time, you can address those market failures. But the key is try not to disrupt the delivery system while you're doing that. And that's the key negative to rate setting and government intervention. So I'm trying to provide a more balanced view of how to approach this.
Yeah, I do really appreciate that. And I guess the last, you've sort of answered it, but like, how quickly can you do this incremental change? Like, I think people are desperate for change. So
Yeah,
that's sort of the balance that I'm struggling with.
yeah. Well, I think, in the time frame you've laid out, it's very ambitious, but I think it's feasible in the next several years to implement reference-based pricing, start to kind of tie that into a simulated global budget. How are we doing with reference-based pricing? If we had a global budget, what would be the outcome? You can do that in the next 2 to 3 years. And then if things are moving reasonably well, consider this idea of applying to CMMI, CMS for an all payer waiver with all payers including Medicaid. And then, illustrate, look, we've had success with this. This is the theoretical approach. There's a lot of literature to show that it's worked in the past, and then go from there. But again, do not take precipitous, significant changes that could disrupt the delivery system. It's hard to do that now, given how screwed up the delivery system is, with this market-based approach, I realize. So I still think regulation is much better. But, just good to keep that in mind, that regulation can also create problems.
Thank you. Those are my major questions, so I appreciate your answers.
Absolutely.
Great. I'll jump in next. Good afternoon, Bob. Thanks for coming. It's nice to see you again.
Yes.
Um, I wanted to talk a little bit more about the volume adjustment that you describe. What interests me about it, kind of from a theory standpoint, when we talk about not paying more for more services, there's a reaction that providers would be incentivized to cut back or stint on care with global budgets. But in reality, what we've seen is a different behavior, that they ramp up utilization to maintain or maximize overall revenue, if
Yeah.
I've read your material correctly. So I'm wondering, with the volume adjustment that you have now, it's for utilization, but it seems like with some newer technologies, organizations could stint but upcode the severity of their patients. And I'm wondering if you've seen any of that or have any advice on how to watch out for that. What are some early signs that we may want to look at, or how would we approach that type of analysis?
Yeah, that's a real phenomenon. It occurred in Maryland for different reasons. So we moved from a less refined case mix adjustment mechanism to a more refined, all payer case mix adjusted mechanism. As soon as we made that shift, hospitals, particularly the academics, figured out, oh, we can just add more information to our medical record, and that creates upcoding, and we get more reimbursement for not doing anything other than changing things on a piece of paper. So, and you see that in the Medicare Advantage market, and so on and so forth. That's harder to get at, but if you're collecting data and data that includes, coded case mix information, you can monitor that over time. What we ended up doing is putting in a basic regulatory, what I'll refer to as a governor, like governor on an old Model T, that governs the acceleration up or down. We put in a governor over the amount of case mix that was considered to be real and recognizable. That again, it's an estimate, so it's not completely accurate, but that hospitals are upcoding. You can quantify the amount that they're upcoding by looking at the status quo and the change, and you can downsize the amounts of revenue that you're giving them because this phenomenon exists, and you can do it on an individual hospital by hospital basis. So that's another thing that the board would need to be mindful of, moving to global budget type of system, is the potential for upcoding. Because if they're legitimately getting sicker patients or older patients, they should be paid for it. But if it's upcoding, that's fluff, and it needs to be monitored and capped. You can't do it precisely, but you could certainly cap it in the context of a rate setting system, what I've described.
Great. That's very helpful. It seems to me that a population of people could only get more severely sick somewhat slowly.
Yes.
Other than a pandemic,
right,
or an epidemic. So there'd be some time frame for that ramping up that we could compare what we expect.
Yeah, but that phenomenon we certainly experienced, and again, with rate setting, squeeze down on the balloon in one area, and then you get a sort of a reaction elsewhere. You just have to be constantly collecting data and monitoring things, making incremental adjustments to address those sorts of issues.
One last question. You spoke very nicely and excellently about political pushback, regulatory capture, regulatory failure. And my takeaway from that is that these are somewhat normal experiences if left unattended.
Yes.
So it takes diligence. You have to be working to prevent it,
right.
or it happens. I'm wondering, you've said a little bit about the structure of an independent board and the leadership. I'm wondering if you could share any more insights about the political pushback. Have you learned any mitigation strategies, any further thinking there about anticipating how this might play out, and what a board might do.
Yeah, again, I circle back to my own experience, which is, kind of what I use as the basis to write the article. But I think two things. One, leadership, which is hard to quantify, but um, you know, there is a tendency you don't want people in your face yelling and screaming at you, and as a regulator, you don't want the legislature pounding on you, and those sorts of or when you're meeting with the industry day in and day out, or week in and week out, and you're hearing, those sorts of psychological influences. Those are the things you can't prevent, but you can certainly try to help protect commissioners and protect your staff by avoiding excessive interactions, and being a receptive and communicative body, but a little bit aloof, because and the way to do that too is also the use of very, very explicit performance metrics, so that even if you start to vary from your mission of not being captured, you could see definitively you're not performing as an agency, and consequences associated with that. So those are two things: create some distance between the staff and the agency and the regulated industry, and have a constant focus on meeting your performance metrics and consequences for the overall industry and the system if you're not meeting those performance metrics. I think those are very important. If you could do restrictions on this revolving door, which exists for commissioners and staff. First, pay your staff comparable to the industry. That helps, as something right off the out of the box. But then having a restriction on them going to work for the industry after being part of the regulatory structure, I think, is also very important. These other types of mechanisms that I mentioned, the adherence to the public nature of what you're doing, the Administrative Procedures Act, having everything in public, those are also important. But part of using the metrics to show that you're performing and meeting those targets is also part of that public nature of what you're doing. All of those things together, I think, are very useful. But the people you hire, the people that are on the board, it's hard to quantify this, and people change over time. But individuals that are less subject to those types of influences are important to have leading the agency. I don't mean to cast compliments to you unnecessarily, but I think you have a good set of commissioners given your background and also leadership at the current point in time, and I commend you on that. And that's just my own personal experience relative to what I've experienced in Maryland and other states. And your structure lends yourself very well to being an independent body, hopefully relative to other powerful entities in the state like the legislature and the Department of Health. So retain your independence, and try to plug any sort of things like revolving door options for people who can influence you.
Thank you very much for your thoughts and your time today. I appreciate it.
Yeah, sure. No, happy to.
Thanks so much. Appreciate you. I guess my question is really around, we know that there's all these incentives in fee for service or global budgeting around utilization, right? We sort of know that there's, depending upon the payment model, there's going to be different types of incentives. And I guess I wondered, we're living in a state right now where most of our hospitals are actually generating negative margins, or break-even margins at best. And we have severe access challenges right now. In specialty care, wait times are extraordinarily long, even for high margin services like X-rays and MRIs. Patients are waiting a long time, often, to get those services. And so I wonder if you could talk a little bit about, even in a flexible model, right? If you push down volume, the price comes up. So as I think about that, I mean, there's still going to be incentives driven by the payment model around providing access to care. And I'm wondering, we're going to absolutely need incredible monitoring for access to ensure that our patients are getting the care that they need, the appropriate care that they need at the right time in a reasonable time frame. So what practical advice do you have for how we can be very careful about monitoring access and ensuring that how we change the payment model doesn't compromise people's abilities to get care in a timely way?
Well, I would recommend against making too many adjustments to the core regulatory model, but one lever you do have in a flexible global budget model is you could skew it more toward fee for service. And instead of using that 50-50 example that I mentioned, 50% variable cost, 50% fixed cost factor, you could make it more variable. You could start out at 60% or even 70% variable, 30% fixed. So that approximates more the incentives of a fee-for-service model, but not as extreme as a fee-for-service model. Then you could cap all that because overall you would have the ability to update hospital budgets to meet your overall target. So underneath, during the course of the year, physicians and hospital CEO, CFO decision making is more based on that more generous or flexible global budget approach, which more approximates fee for service. And then over time, if you start to realize, no, access is not an issue, we're not worried about under provision of care, you could readjust that over time. Now, and again, we had recommended two different approaches in Vermont. The larger IPPS hospitals, more like a 60-40 or 50-50 variable fixed cost adjustment. And for the smaller hospitals, something a little bit more fixed, like 80-20, because they have higher proportions of fixed costs. So this model is more kind of economically based on the cost structure of hospitals, and you'd want to try to titrate it to a degree. Again, there's regulatory failures, so you don't want to make things too differentiated and too complicated, but those types of adjustments are available, so you can titrate the system depending upon your needs. The other thing that I would mention is that because you have a high proportion of hospital-based physicians or hospital-owned physicians, you could simultaneously work on a payment system that would align the incentives of the hospital-owned physicians with the global budget as a way of dealing with this issue. And also, one of the things we had recommended is working with your FQHCs in your regional delivery system to make sure that they are funded sufficiently to provide high levels of preventive and primary care. I mean, in Rutland, we were working with Tom Hubner and Grant Whitner, and we thought that was a classic example where there's another area that I believe the hospital owns the FQHC or vice versa. So integrating more of the incentives of the care providers themselves to be consistent with the incentives of the global budget is another way of trying to address this issue of access and emphasizing FQHCs and your delivery system there and primary care, and then trying to align the incentives of the hospital-based docs. I think would be a way of trying to approach this.
Yeah, thank you. I appreciate that. I mean, our ability to titrate it is going to be based on our ability to measure access. And right now we have self-reported once a year wait times by hospitals. So, we may have to fine tune our ability to understand access and access challenges to be able to titrate it. And, we have a rough brushstroke right now at access, I would say.
One way, I mean, in Maryland with the fixed budgets, I think that it resulted in stinting on care, and we had tremendously high ER wait times after the fixed budgets went into effect. So that's one of the things you could focus in on, collecting that type of quality data. You can also look at the CMS experience of care data, but then you can tie those metrics to the actual rates of the hospitals, where we try to provide incremental rate increases for hospitals who are meeting those quality metrics and access to care metrics, and then penalize the hospitals that had the longest wait times, as a kind of overlay to the core rate setting global budget system. So there are ways of trying to address it that way. But again, the caution is don't make the system too complicated. Over time, there's a tendency to do that. But you can get at it more directly by doing that.
Got it. Thank you so much. I appreciate it.
Yes, absolutely.
Yeah, it's interesting, the regulatory capture conversation. One of your notes was don't have people with ties to regulated industry. And we have two, Dr. Merman and Member Teachout, and I would not classify either of them as remotely captured. So
Right.
sometimes it is personality based.
Oh, yeah, big time. I agree.
And to their credit, they have strong character. One thing that we've done at the board, really frankly influenced by you, is we have used our budget enforcement mechanism in a bit of a way of a flexible global budget. We've set those total NPR caps, and when hospitals have gone over, in certain circumstances, we've let them keep 50% of the overage, and we use 50% to drive down the pricing, which gets to a more reference-based pricing model. In other situations, they've kept all of it if it's appropriate in our judgment. And in others, we've used 100% of the overage to drive down the prices. And I do think there's a sweet spot there in our enforcement mechanism to look at, hey, should they keep 30%, 40, 50%? What is it? So we have exactly what you're talking about.
Yeah, that's great. I'm glad there was that influence. Absolutely.
Yeah, I think it's been a successful way for us to do it. I think in hindsight, looking back at how we've used that authority, I think we've got it right.
Yeah.
I do think the decisions we've made were correct.
Yeah, I would just caution you a little bit. There is some benefit to having a kind of a global system that's a little more uniform rather than requiring the board or the staff to go in and say, oh, this looks out of kilter, we'll make this little adjustment here or that. If you could have an overall system that has these more formulaic elements to it, that makes it much easier to administer. Now, it doesn't prevent the board from coming in, taking your hands back on the wheel and saying, okay, in this case, we have to make these sorts of adjustments for this hospital. And we did that. We did that periodically. If there was a rural hospital in an underserved area that was struggling, we could actually increase their rates to get them over a rough spot and then bring the rates back down eventually. So you have that capability, but be careful what you wish for there because it can be challenging politically.
I've thought about the more formulaic approach, and part of my hesitation on it is that there are so many ways when you have a formula, it can be gamed or avoided. And I find as a regulator, I feel like I'm often behind what's going on, outside of where we regulate. For example, one of the reasons we've enforced budgets in full has been when we get the budgets, perhaps what was disclosed in the budget on the Medicare reimbursements was, I don't want to call it nefarious, but not accurate. And then that influenced how we ultimately made the budget decisions.
Yeah,
But if we had a formula, it would be very unlikely we would have captured that. It's only through a significant amount of diligence and work by our staff and the other board members that we recognized it. So I get nervous about the formulas a little bit.
Well, I think the two aren't mutually exclusive. I mean, you could still, and we've experienced this as well, is that the squeaky wheel, no, it's more the balloon effect. Every action you take, significant action, is going to create a reaction. So you have to monitor those. But if you have strong enforcement, and it, tying to your formula-based approach, you can basically achieve the results you want. And going along the way, if you see that the people are gaming or submitting inaccurate or non-timely information, you have the ability to impose huge fines on the hospitals and call them out publicly if they're doing that type of thing where there's some misrepresentation of information or you're not getting the data that you need. So the one thing I didn't emphasize as much is data collection authority and the ability to impose, consequences on hospitals if they're not sending you accurate or data is very important as well. And so you can kind of try to plug that hole. Doesn't mean that you wouldn't be monitoring them, even though you have a formula-based approach. You monitor it, you pick out the fact that they're upcoding, you pick out the fact that they're giving you inaccurate data, then there are consequences associated with that. And pretty quickly they jump in line and you don't have that type of problem nearly as much, particularly the public aspect of it too. In addition to fines, calling out the hospital publicly for providing inaccurate data is a tool in your toolbox.
We have definitely experienced that, and it does appear that those kinds of issues are in the past. I hope so, and it seems like that's the case in our experience.
Yeah.
Okay, I had no other questions, but thank you very much, and Bob, really good to see you. If you don't mind, I'm going to take public comment, and if you want to stick around, you can.
Yeah, sure.
great.
I'll be happy to stick around and just tell me if there are any specific things you want me to address in the comments. I'm happy
Sure.
to.
Great. Okay, and with that, I will take public comment via raise the hand. Ms. Wasserman?
Yes. Good afternoon. Excellent day. Great presentations. Really impressive. But I have just two comments. One, I think we need to continue thinking about how all this great work that we're embarking on will reduce premiums, because that's really the end goal, at least in Vermont, where it's unaffordable now to even be covered with insurance. And then the second thing is that we have a serious shortage of primary care physicians. And if we're going to pressure hospitals to reduce costs, we need to address this shortage straight on. And I strongly advocate for a retention and a recruitment plan, a statewide retention and recruitment plan for primary care physicians to complement the great work you're doing. Thank you.
Great. Mr. Schultheis?
Sure. So two things. One is I agree with Board Member Holmes about access kind of being the challenge. I think I want to push on us thinking beyond just wait times and how do we get at potential access. I think Board Member Holmes, this is just a story. I think you remember that man at one of the public comment sessions who cut himself and his family wanted to call ambulance. And he was like, no, I'll just bandage it. The ambulance is too expensive. Like, how do we measure that person? And how do we measure what the barriers are, like price or other factors that inhibit usage? And, of course measuring potential access is kind of this perennial problem in the literature, whether you're looking at healthcare or, at least as I know it, like access to social services generally. But they're proxies, like, are the demographics of the people who actually use the service, who are on the wait list, changing? That could be, or is the severity changing over time? And we might get some measures that are thinking about this potential population. I think it's also important that we have some consumer-centric measures, particularly around price. The other thing is, Mr. Murray, I thought your 2022 article in Health Affairs was amazing. I was wondering if you had suggestions where, and it was kind of hinted at this, the kind of political situation that occurred in Maryland from 76, I guess, to 1990 around the volume adjustment system. And, you mentioned that, and I was wondering if there's anywhere folks could look to find out more about the politics of the Maryland system, other than your article in Health Affairs, and then the site you have in that article to Berenson's Urban Institute paper. Well, it's yours too, right?
Yeah, I could. Well, that's just one thing I'll mention about the 22 Health Affairs article is that this is a topic that came up earlier. So hopefully I'll get to your question directly, but I wanted to mention that it was based on a theory that we had that rate setting could actually improve the competitiveness of a hospital system. And we found evidence in Europe where, and again, this is a point I've made ad nauseum, but the rest of the world has rate setting. There are all the developed countries in the rest of the world have rate setting for providers, and it works. But one sort of consequence of that is that because hospital prices are regulated, they tend to compete on other things like quality and service more effectively. So that's one of the side effects of rate regulation, is it can actually improve the competitiveness. I wouldn't hang your hat on it completely, but it does have that type of intended result. But then that article in 22, and just my work on capture, that volume adjustment was kind of transparent. Or unknown to the general public or unknown to the legislature. So they didn't get involved they just saw the end result, which was formulaic, and we met our performance standards. And that's all they cared about. Yeah, there were complaints they would get from individual hospitals and so on, but they figured, well, if we tamper with this, then we lose the Medicare waiver, the whole thing blows up, and so I want to stay clear of this as long as things really aren't off the railroad tracks. And so that's the value of a more formulaic system. If things are going well, it tends to sort of give you less vulnerability from a political standpoint. And the legislators don't want to get under the hood. They just refuse to, look at that level of detail. So that's in your advantage as well. So I think there are advantages to having a more formula-based system if you're meeting your performance goals. And of course, there's a lot that goes into that, but regulatory enforcement, and then for collecting correct data, penalizing hospitals for incorrect information, and also penalizing hospitals if they're not in compliance. Those are the two tools that you have that really make the system work well, along with this more formula-based approach, which can be modified, but hesitate to make frequent modifications to your rate system. So I don't know if I just saw all your questions, but I'm happy to do follow-ups.
And just really quickly, what made the volume adjustment system not work in this second, like post 1990?
Yeah, I'll take some responsibility for that. When I first got there, it had been watered down significantly. It was 50-50 for most of that period, 76 to 92. But then in response to that pushback that I referred to, political pushback, the previous administration watered it down. So it was 85% variable, 15% fixed, no volume adjustment for the academic medical centers who are more politically powerful, for outpatient. And then, so it was really winnowed down in its effectiveness. And then we got into a period where we were struggling on our Medicare waiver, which is more price-based. We ratcheted down on prices and volumes exploded. But in the meantime, doing that to negotiate that ratchet down on prices, I removed volume adjustment. So the combination of extreme pressure on prices, removing the volume adjustment, and there's an article that I've written, I don't know that it's cited, volumes exploded in Maryland. It was like flipping a light switch. I was shocked the power that the hospitals had to increase volumes unnecessarily. So that sort of illustrated that trade-off. And you have to be mindful of abrupt changes or significant changes in your regulatory system. So that's what occurred during that period. And then we eventually brought back the volume adjustment, and that's when our staff implemented the global budgets for the rural hospitals, which then dovetailed into the current demonstration. But they used a fixed budget approach, which I think was problematic.
Great. Thank you so much.
Yes, you're welcome.
Okay, Stephanie Brilt from Northwestern Medical Center.
Yes, thank you. I actually wrote my comments, so I'm going to read it if you don't mind. For those of you who don't know me, I am Stephanie Breaux, and I'm the Chief Financial Officer at Northwestern Medical Center in St. Albans. I want to thank all the presenters today and the board and the staff, and thank you for the opportunity to provide public comment. Northwestern supports this work, and I agree with much of what was discussed today. What scares me about reference-based pricing is the concept that if a hospital's current price is under the established cap, the price must remain where it is. And we saw this with Act 55. As a low-priced, high-quality hospital that demonstrates expense control, I am quickly burning through days cash on hand, and the inability to come up to a level playing field means that I will continue to go out of business. And it means that I still can't compete for a workforce with other hospitals that would continue to get paid more than I do for the same services. Oh, can you still hear me?
Yes.
Okay. Price caps have potential to meaningfully help Vermont with affordability issues, even if that means that some hospitals may have to implement an increase. And I understand that some hospitals, such as mine, have high days cash on hand, but at 190 days cash on hand, just a handful of years ago, I was at 300. So I feel the clock ticking. And, my goal is really just to make sure that the St. Albans community continues to have access to care locally. So thank you.
Thank you very much, Stephanie, for commenting and attending today. Alex Claire?
Sorry, my camera doesn't work, so can you hear me?
We can.
All right. So just a couple things to point out. So we're an outpatient PT clinic. There are several of them. The Medicare reimbursements in 2018 were 6.8 to 13.5% higher than compared to what we are receiving today for the same service. That is a huge hole in our budget, obviously, which leads me to just the price difference between different entities using Medicare reference-based pricing. I did pull the UVM Medical Center outpatient clinic pricing. Their prices range from 263% to 410% of Medicare outpatient pricing for my insurance carrier if I were to go see them. That is grossly inflated. I can speak to the PT industry. I'm sure other PT clinic owners would agree. A 200% price cap on Medicare pricing for physical therapy services is more than enough. And I just wanted to encourage the board to go as low as possible while also realizing that there are some hospitals that are struggling, but our academical medical center is not one of them. So that is my comment.
Okay, thank you, Alex. Any other public comment at this time? Great. Well, thank you for being here, Mr. Murray, and thank you for to Elena and Kirk for putting on a really tremendous and informative agenda today. A really important building block for a lot of the work that the board's doing. So thank you, everyone. And we have one other agenda item, which is the Data Governance Council Charter update. Is Ravi here?
Yes, Chair Foster, I'm here.
Oh, great. I'll turn to you to walk us through, and we have noticed a potential vote today.
Absolutely. Thank you very much. Once again, good afternoon, everyone. And thank you, board members and for Chair Foster for this opportunity. So at our last meeting, we discussed the proposed new charter, and then there were two suggestions for changes. And in addition, we found another typo. So all in all, there are three changes. So I will quickly go through the document to show where the changes are, and then we can go from there. So I will start sharing my screen, so please let me know when you see it.
We can see your screen, Ravi.
Thank you, Chair Foster. So here is the document that summarizes the changes and highlights the changes that we have made since the last meeting. So I will scroll down. So this obviously is the latest version, which is the 1.5.2. And I'm scrolling down quickly. Oops. Yep. So here is the first one, which is last time the suggestion was, to rephrase, the word purchase, that has since been updated. And then the next one, if I scroll further down, is about right here, the typo that I was talking about, there are 4 distinct roles, whereas the last version only showed 3, so that has been updated. And the last one is about the executive director still being able to fulfill the role of the chair. So the language has been clarified to state that in the event that the GMCP staff member designated by the executive director is unavailable, the executive director may still fulfill the role. And the rest of the document remains as is.
Robbie, can I jump in with one little thing?
Yeah,
There's
absolutely, Ms. Pat.
yeah, there's technically going to be one other change, and I'm sorry it didn't get reflected on this version, but it's with the table of contents, and that's kind of funny with the dot compare. But there was another typo there where one of the sections, I think it was section 3.2, wasn't showing up in the table of contents correctly. And so I just updated that table of contents to reflect that section to be listed. And there's going to be one other change, which is some changes that we made based on the accessibility guidelines to make sure that all of our documentation is accessible to everyone. And so the final version, it looks different. It has different like headers, like the color and stuff is different, but the substance is all the same. It's just how it looks and using that accessibility template. So I just want to call out those two things real quick.
Thank you, Julia.
Great, thank you both. Is there any, well, actually, I'm gonna make a motion, then we can take any board discussion, but Ravi or Julia, is there anything else?
Nope, those are all the things. Thank you.
Perfect, okay. Then I move to adopt the Data Governance Council Charter version 1.52 as included and described in today's presentation.
Second.
Any board member discussion or comment? Any public comment? Okay, then all in favor, please say aye.
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 Aye, and the charter updates are approved. Ravi, congratulations, your first board hearing, and you had a successful vote, so great job.
Thank you. Thank you very much, Chair Foster. And thank you, board members.
They only get easier from here. I believe that's all we have on the agenda today. Is there any other new or old business for the board? Okay, hearing none, then I move that we adjourn.
Second.
All in favor, say aye.
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 Aye, and we're adjourned. Have a nice day. Thank you.
Thanks all.
Thank you.